Good morning. If you can hear me, you can
Good morning.
raise your hand. Yeah, good morning. Um, Welcome to the new semester. And Victor, I hope you are in the house.
Yes.
I think you can give us a go ahead. You can tell from the attendance if we have quorum. Is it? Do we?
Yes, I think we can begin as the others continue to join.
I do not want them to miss, though, but just begin because in the interest of time, we can begin. Now, I think did we do it? Did I take through you through chemotherapy one?
No.
Someone else did, right?
Yes.
No. So this semester we shall go through chemotherapy two. The reason for separating the 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 different antibiotics is should give you a scope of how extensive or how many antibiotics are available. So you'll be studying it throughout. Maybe there's another chemotherapy after this, but I think this should be the last one. You did a lot about. I know about cephalosporins and beta lactams and aminoglycosides, such like things. So this semester, hoping there's no strike again, we shall go through the remaining antibiotics. So we shall talk about chloramphenicol. Formerly, it was a very popular drug until fluoroquinolones came to the scene. Now we usually have chloramphenicol in the market, but as a third or fourth line drug when the bacteria is not responding to first, second, or third line treatment. We have macrolides, and today we shall talk about macrolides. Pretty much very common, like not really common like beta lactams or cephalosporins, but all the same, they're considered, equivalents or alternatives for beta lactams, especially if somebody has an allergy. We have glycopeptides, bacitracin. These ones usually used externally. We shall also talk about fluoroquinolones. Then UTI, management of UTI. Later, we shall talk about TB. We know that Kenya is one of the countries that's having a high TB burden. So the transmission is quite high in our country, and the treatment is a priority. One of the conditions set aside that run as a program is the TB leprosy program. And I know we've been adversely affected by the US cutting funds, but I know the government is putting a lot of money into the treatment, especially procurement of drugs. Antifungal agents. I know the other syllabus may have covered antifungal agents. I don't know if you have. Have you covered antifungal agents? I can't hear you. I can't see, so you should tell me. Have you covered, Victor? Yes, not yet. So we shall also cover. Um, ARVs on use, when and how to use them. After this, you're expected to know how to use all these drugs, especially in management of HIV and TB. So this is all that we're supposed to cover. It's not a very long topic, meant to be easy. So I want us to enjoy and ask questions where we can, and then participate. I like it when we also offer ourselves for discussion, right? Then now we go straight to today's topic, which should be macrolides. All right. We shall talk about macrolides, the main topic. Then we shall add other smaller or less used antibiotics: polymyxin B, colistin, vancomycin, linezolid, and bacitracin. Now, let's jog our memories. I know we've gone through this in pharmacology in chemotherapy one. I'm sure the lecturer showed you this. And the reason why we need to learn about the modes of action of these drugs is sometimes we combine these drugs for purposes of synergy, especially if one is showing, that it can't kill the microbe on its own. So we have to enhance the activity using another drug that acts on a separate site. So that's very important. And in chemotherapy one, you were taught about, is my screen visible to you? Is it?
Yes, it is visible.
Yes, you were taught about antibiotics that are bacteriostatic and those that are bactericidal. Remember?
Yes.
Yes. Generally, antibiotics that are bactericidal. Where do they generally act? The bactericidal ones. Where do they generally act on the cell?
Mostly on the cell wall.
Mostly on the cell wall, right? Now, do we have antibiotics that act inside the cell but are bactericidal? Do we?
Aminoglycosides.
Aminoglycosides are an anomaly, right? So because they act the ribosome, but they are usually bactericidal. Now, and then the situations where we have to, combine bactericidal, bacteriostatic antibiotic. So what do you think if you give somebody as bactericidal and bacteriostatic antibiotic, what do you think I want us to jog our memory before we proceed so that we don't learn chemotherapy 2 in isolation.
Maybe I can try.
Yes, boss.
Bactericidal
mostly work on slow-growing bacteria, and bacteriostatic uh, mostly work on fast-growing bacteria. So you'll find each antagonizing each other.
You are almost there. You are almost there, boys. All right. You said bactericidal should act on slow dividing. Yes. Yes, Odinga.
I think it's the other way around. The bacteriostatic act inhibit the bacterial growth, but the bactericidal require the actively dividing bacteria, so that when you combine them, they antagonize each other.
They will antagonize each other, right? That's good. Then most first-line treatment in hospital, right? The very drug you'll find is a combination of gentamicin and penicillin G. Okay, so how do you justify that combination? So do you think that combination is wrong? No, it won't be wrong because as much as they act, one acts on the ribosome, they are all bactericidal, right? I think I started by mentioning that. So these are the general targets for antibiotics. And for DNA, we have fluoroquinolones, and we shall discuss them extensively. We use them a lot, and when they came, they saved a lot of lives. However, we have to use them with a lot of sense of keen because the side effects are quite long lasting when they take root. For those targeting 50S, for today's topic, we shall talk about macrolides. And generally, they target 50S. So now you know why we cannot give a patient an aminoglycoside and a macrolide at the same time. Then nitrofurans will affect the 30S alongside tetracyclines. Then we have those affecting cell wall. We know about beta lactams and cephalosporins, and also drugs like vancomycin. Then for those affecting cell membrane, we have lipopeptides and polymyxin B. This one's normally for polymyxin used as a topical preparation. Antimetabolites, these ones will act on stop formation of para-aminobenzoic acid. And the common example is cotrimoxazole, combination of two drugs that act stepwise to stop formation of para-aminobenzoic acid. Right? Line drug for TB, the mainstay for TB treatment, as well as treatment of other conditions that require, long-term treatment. Rifampicin is really effective in management of bacteria that don't usually respond to many antibiotics. Now, so we shall dive directly into what macrolides are. And, I've been reading about a new class of antibiotic being developed, and it has come as a result of purely an accidental discovery. And when you learned about penicillins, the discovery was accidental. On macrolides, the discovery was accidental. So people who happen to work in the lab make observations, and a molecule is extracted that changes life and saves life for generations. Now, macrolides usually have this ring. They named, this is a macrolide ring. From PharmChem, they shall name them for you and number them for you. So I won't go into that. But you realize that the side chains are generally the same. And just by looking at this molecule, it tells you that the size is big. It's not a molecule that can cross the blood-brain barrier. And alterations on this first ring is what macrolide, right? That was isolated from Streptomyces erythraeus. So this one gives is the name. Then when you methylate this part, expect this to be a more stable molecule because you remove the ketone. So azithromycin, now it's a receptor. And the advantage is that it has a very long duration of action, and because of that, it accumulates a lot in body tissues, has a good volume of distribution, and it has an advantage of being taken once a day. Then we have clarithromycin. This one has, because of the methylation here, I think it makes it less polar. Then it can penetrate bone tissue quite well, and very effective management of gram negative or gram positive aerobes. Okay, so you'll find it as a common treatment for conditions such as H. pylori infection. Right. So azithromycin is a newer compound, and it's a good substitute for azithromycin for certain conditions. Then we have now a new class called ketolides. So ketolides, an example is telithromycin. It's been authorized for use. However, it has been observed to have a lot of side effects. So it's a drug that will be reserved for use in certain conditions where the sensitivity and first, second, or third line drugs have failed, right? So that's the classification of those drugs. Look at their spectrum of activity. Now, their spectrum, the first thing you have to learn is they're bacteriostatic, right? And but at high concentrations, they may be. Have you discussed that has such properties? That is at bacteriostatic, but at certain concentrations, they are bactericidal, which are the antibiotic. Any that you've discussed before? So go remind yourselves about that. This is not the only example of such an antibiotic. Now, resistance is quite common for macrolides. You realize that erythromycin is now not very commonly used. And amongst group A strep isolates, and which are group A strep bacteria? Examples. From your microbiology, examples of group A strep. Have we forgotten?
Streptococcus pyogenes.
Those are group A strep, right? So
Yes.
so you see the resistance is quite high. 40% is quite high, right? And the bad thing is during COVID, which antibiotic did people abuse most?
Azithromycin.
Azithromycin. There was a lot of voodoo science, and anything written as a scientific evidence was being quickly implemented. People really abused azithromycin, and because of that, we expect azithromycin to be less effective going forward. Be sure that we have so many isolates now that are resistant to azithromycin. The same way people abused cotrimoxazole, and now really we use it for prophylaxis and nothing more. Now, then we have a cross resistance with penicillin, right? So only 5% of penicillin susceptible strains are macrolide resistant, so that's an advantage. But 50% or more of penicillin resistant strains may be macrolide resistant, right? Then because of that cross resistance, now you expect that if a penicillin works, a macrolide may work, or there's a possibility that it's not. Erythromycin is inactive against most aerobic enteric gram-negative bacilli, right? How does it act? Now, we know the structure of the human ribosomes, right? 50S, 30S. So macrolides usually bind to the bigger subunit, alongside which other which other?
We have clindamycin.
No, that's this is a macro law. That's a macrolide. Which other class?
Chloramphenicol.
Chloramphenicol targets the 50S, right? Which one does like for example, gentamicin, aminoglycosides, where do they target? Should be the same, right? But then the subtle differences that you should know, those that target the translation proper, those that target translocate. Okay, like these ones will just bind here and prevent addition of any extra amino acids, so the chain elongation will be terminated, right? So that's how it works. Then how does resistance develop? Resistance develops quite rapidly against aminoglycosides. And the first thing is you should know that different bacteria will have different mechanisms of resistance against this group of drugs. So for Staphylococcus or group A strep, they usually develop methicillin resistance gene, okay? Or they develop for MEF, this is purely an efflux pump, okay? As long as the drug cannot achieve certain concentration inside the cell, then it can't be effective, because anytime it enters, it's usually pumped out of the cell, right? So this one for the pump, okay? For the efflux pump, usually for strep pneumonia. For group A, usually they develop MRSA, for example, Staph aureus, for example. Then ribosomal protection, remember it has, at a certain point, there's addition of methyl or small chain groups at that point where it's supposed to attach, then it means the molecule cannot develop, its conformation cannot bind to that pocket because of hysteric hindrance. So there's this production of enzymes that produce methyl group and methylate the active sites for these drugs. So it means the drug cannot be effective. Then that they have weak points that can be hydrolyzed, okay, by hysteresis, especially by Enterobacteriaceae. Then chromosomal mutations that alter the 50S protein such that it has a strange conformation. So the drug can be there, not hydrolyzed, but it can't bind because the conformation has in Campylobacter and Mycobacteria and some gram positive cocci. You write this, okay? So you go discuss the pharmacokinetic properties, the spectrum of antibacterial activity, which side effects do you expect when you use erythromycin, azithromycin, clarithromycin, right? And these are the drugs I want you to go and look at. Erythromycin, which is the base drug, right? Clarithromycin, telithromycin. And because I said telithromycin has shown to have several side effects, we should be in a position to know why it's not a very commonly used macrolide, right? So for macrolides, that's as far as I want us to go. They're extremely commonly used drugs, right? You'll come across them every day in your practice, and you have to know when to use them, the interactions, and the contraindications, for example, so that you learn, okay, when to use them. Now, we go to antibiotics that you will not meet very commonly unless you are in well-established facilities. Now, lincosamides, an example is clindamycin. Now, it's the only member of that group, and its mechanism it's quite similar to that of erythromycin, and it has shown to have cross resistance with erythromycin. Now, because if there's methylation, then which means also clindamycin will be affected. And antibiotic efflux is not an important mechanism of clindamycin resistance. So for it, methylation is what actually affects it. Its spectrum is mostly gram-positive cocci, including most species of strep penicillinase producing staphylococcus, but is not active for MRSA. Also, it's effective against Clostridium, diphtheria, Nocardia, actinomyces, Toxoplasma, and has a slow action on Plasmodium, right? So it means clindamycin has an effect on protozoa, right? Now, it has activity against a variety of anaerobes, especially Bacteroides fragilis, but does not have activity against gram-negative aerobes. which including bacilli, spirochetes. These are generally special kind of bacteria that needs other drugs that we shall discuss about. Chlamydia, I'm sure you've discussed about when you discussed about aminoglycosides, you learned about atypical bacteria. You learned about atypical bacteria? Yes, what are these atypical bacteria? Francis.
They are bacteria that do not fit the category of gram positive or gram negative.
So they don't have all the structures that can make them to be defined as bacteria, right? So then for those ones, you have to target their, you cannot target the cell wall, so you have to target protein synthesis, right? So which drugs do you think are effective against, and actually whatever we're seeing here, basically atypical bacteria, right? And chlamydia. Okay, so where do we get chlamydia? Where does chlamydia affect? Usually,
Chlamydia is a sexual transmission.
Julius?
Yeah, it's a sexually transmitted.
Chlamydia, that's chlamydia, the protozoa, right?
Yeah, the toconomatis.
Yeah, forget about that one. We usually have chlamydia that causes pneumonia, right? You know it?
The chlamydia pneumoniae.
We have chlamydia pneumoniae, chlamydia psittaci, right?
Yes.
Yeah, so you'll find in hospital, you'll have a patient with pneumonia-like symptoms not responding to, because for pneumonia we know the management has to be beta-lactams or cephalosporins. If the patient is not responding, you may have to suspect chlamydia, and then you have to change to drugs that target atypical bacteria. So that's a common thing, something you have to be aware about as you go out there to practice. Now, so clindamycin is usually given orally. Okay, its oral bioavailability is good. It penetrates into most skeletal and soft tissues. That's why I've said for bone infection, clindamycin is a truly useful drug alongside certain fluoroquinolones. But it does not cross the blood-brain barrier, does not enter the CSF. However, it accumulates in neutrophils and macrophages. Its metabolism is via CYP3A4 enzyme, and I think I've said so many times that CYP3A4, of all the cytochrome isoenzymes, CYP3A4 and A5 will do 75% of oxidative drug metabolism hepatically. To a lesser extent, CYP3A4. Okay, so any drug that upregulates CYP3A4 will decrease the concentration of clindamycin. So it means then the dose of clindamycin has to be increased, right? Then its half-life is 3 hours. You expect a patient to develop rashes, urticaria, abdominal pain. And a problem that the patient may develop is diarrhea, and that's very common for also drugs that have a broad spectrum of activity. I think we learned why. Did we learn why? If you give a patient, especially in children, a broad acting antibiotic, they'll develop diarrhea after a short while. What do you think that happens?
Yes, when you give a broad spectrum antibiotic, for example, like azithromycin, it should also colonize the normal flora, and the normal flora are responsible for part of the mucoprotective properties in the GIT, so they'll have diarrhea.
Yeah, and also pseudomembranous enterocolitis, and so this one has also to be treated using another antibiotic, right? And the reason for that is because of Clostridium. And you know, we sometimes we eat in this country we handle, not so that we eat food that is being handled by people usually who don't have certificates to handle food. We don't know the immunization states, the hygiene states. Um, we eat kachumbari, Clostridium. When you get gastroenteritis, you can go get medication and it works. In some cases, if you have Clostridium that is resistant to treatment, which I've seen not once, it's really a very bad sin. And people die from GE because of that. So, or lengthy hospital admissions. So we should be really careful with street foods because the hygiene levels of food handlers here is not really good. Pseudomembranous colitis, usually metronidazole is a good option, or if that can't happen, then vancomycin is an alternative. Now, what are the uses of clindamycin? Because of potential toxicity, we've talked about that, and a drug that is metabolized by CYP3A4 has a lot of drug-drug interactions. So it's usually restricted to anaerobic and mixed infections, especially those involving Bacteroides fragilis, that will cause abdominal or pelvic and lung abscess. So it's restricted to use in such scenarios. It's a first-line drug for management of abscess caused by those bacteria mentioned. And in this scenario, it's combined with an aminoglycoside or cephalosporin. Now, we know why that combination has to be done. Nidazole and anaerobes. And also, it's useful in management of skin, soft tissue infections for patients allergic to penicillins. And which penicillins we usually do use for soft tissue infections? Which class of penicillins? Tumesoma penicillin last semester. So which penicillin do you use for soft tissue infections? I know, we know for sure.
The anti-staphylococcal penicillins like oxacillin.
That's their class? That's their classification? Somebody comes with a with a boil, right? An infection of the skin or chicken pox, and you need to treat because of these spurs. So what do you give? Which penicillin do you give?
Give aminopenicillins.
Aminopenicillins.
Yes, like you can give ambiclox.
Ampiclox is an aminopenicillin. Ampiclox is a combination of ampicillin, cloxacillin, right?
Yes.
So you realize that's not one drug. You learned about halogenated penicillins? Because ampicillin is an aminopenicillin, is it? Alongside
Yes.
amoxicillin. Yeah, so halogenated penicillins, examples?
Cloxacillin.
Cloxacillin, flucloxacillin. So that halogenation usually gives them stability and activity against, Yeah, so we should know. So an option, if somebody has a penicillin allergy, is to give clindamycin because it has very good tissue penetration properties. All right. Then also for prophylaxis of endocarditis, if a patient has penicillin allergy, prevention of surgical site infection in colorectal and pelvic surgery. We've said these drugs are very effective in anaerobes. That's why you use them for internal infection. It's usually combined with pyrimethamine for management of toxoplasmosis. Right? We shall learn about alternatives for that, for toxoplasmosis. Now, where do we get toxoplasma from?
From cats.
Yeah, for those who like cats. So this is because we said it has some antiprotozoal properties. Now, it's also an alternative to doxycycline in treating multi-resistant malaria. We know doxycycline sometimes is useful in malaria prophylaxis, and we've said clindamycin has anti-protozoal properties. Now, the drug interactions. So clindamycin, erythromycin, and chloramphenicol exhibit mutual antagonism. We said this will happen because they'll bind to the same site. The mechanism of action is technically the same, right? So you expect that. We do not even have to have, we do not need that slide for us to remember that. Now, what we have to remember is it slightly potentiates neuromuscular blockers. Then we talk about also an important penicillin alternative, which is vancomycin. Now, early, it was a very good substitute for penicillin in management of MRSA. Spectrum of activity, you expect it to, from the mode of action, which we shall see shortly, this affects mostly the gram-positive cocci, Neisseria diphtheroids. However, in hospital where it's been used a lot, then you expect to have vancomycin resistant staph aureus. That's almost, it's analogous to methicillin resistant staph aureus. Then, so this nosocomial bacteria are resistant to methicillin and most other antibiotics as well. So anything that has a VRSA will also resist methicillin. So we know how if we can remind ourselves, how did penicillins inhibit cell wall synthesis? How did it act, if you can remember? Justin. Yes, Julius?
We're talking about the penicillin.
Yes. We want to draw parallels with vancomycin. So I want us to remind ourselves on how penicillins affect cell wall synthesis.
Yeah, penicillins, they bind to the transcriptase enzyme, which is responsible in the cell wall synthesis in the bacteria. So when it blocks the enzyme, it's not able, the cell is not able to develop.
Can somebody put it in another way? Francis.
It binds to the enzymes responsible for cross-linking, preventing formation of the peptidoglycan.
What are these? No, somebody raised their hand. Yes. Yes. Tunduli.
They bind irreversibly on the protein binding proteins, preventing them from cross-linking with peptidoglycan strands.
So you meant penicillin binding proteins?
Yes.
Yeah, good. So now vancomycin will act on a very different, in a different mechanism. So usually it acts by inhibiting bacterial cell wall synthesis. Here it binds to terminal D-alanine sequence of the peptidoglycan, preventing its release from bactoprenol lipid carrier, so that the assembly of the units cell wall and their cross-linking to form the cell cannot take place. So the last sequence, okay, in that peptidoglycan is D-alanine, two D-alanines together. So that's where the last two D-alanine is where vancomycin will bind, so that this cannot be released, and that means this termination of that process, and the cell wall will become defective, and usually these molecules work by allowing now fluid and water and everything to enter the cell, and the cell will burst and die. Right? That's mostly how these compounds work. Now, how do bacteria develop resistance against vancomycin? So for Enterococcus, it's due to plasmid-mediated alteration of the dipeptide target site. That's the DR site. So it means vancomycin will have reduced affinity to attach to that site. Vancomycin is not available orally, so it's given in IV. And when given IV, it's widely distributed. It penetrates serous cavities, inflamed meninges, and it's excreted mainly unchanged by glomerular filtration. So it's not a substrate of any CYPs in the liver. So within 6 hours of administration, you expect all the vancomycin to have exited the body. That means then if there's renal insufficiency, the dose has to be adjusted downwards. It's quite a toxic drug. It will cause nerve deafness, which may be permanent. Kidney damage, we've seen why that can happen. It will cause autonephrotoxicity. These are similar side effects to what you experience when patients are on some drugs, for example, aminoglycosides. And the benefits outweigh the risks, right? So there's skin allergy, then there's following BP during injection. Vancomycin has the potential to release histamine by direct action on mast cells. I know, am I the one who took you through otoquids?
Yes.
You remember histamine can be released by certain drugs, remember? And vancomycin is one of those drugs. So if you're asked in a in an exam or anywhere out there, if there's a drug that causes red man syndrome, it's usually vancomycin. And if you're asked how it causes red man syndrome, you can easily say it's because it initiates release of histamine, and whatever you see as skin effects of vancomycin is due generally due to release of histamine. So from what you've seen, facility, you're a pharmacist in charge in a hospital. Do you think you can have, you should have vancomycin in your facility? Julius, is it something that you may need?
Yeah, depending on the level of my facility, maybe if I'm in from level 4, because the kind of because vancomycin you may not use it as a first line. You want to use it as either second line or third line. So you may keep it especially for maybe severe infections.
You will need this drug, right?
Yeah. Yes.
Because you learned about vein, you learned about vein analysis. You'll have drugs that are vital, then essential, then those ones that are necessary. So this one will fall in the necessary category because at some point you will need it. So it's a second choice drug to metronidazole for pseudomembranous colitis. You've talked about it because it's a common bowel inflammatory condition caused by Clostridium. Also for Staphylococcal enterocolitis. Then systemically in MRSA infections, okay, it's usually the most effective drug for MRSA. Then penicillin substitute, okay, in conditions of enterococcal endocarditis, and where it's mixed with gentamicin. Then for alternative drug for serious skin, soft tissue, skeletal infections, and for this, especially for skin, soft tissue, you've talked about the first line being which drug? For skin, soft tissue infection, we've talked about it a minute ago.
Allopenicillins.
Yes, those allopenicillins. And if you don't get that, what was the second? Also, the other alternative? Clindamycin, right? Then now we can talk about vancomycin. Now remember the other drugs can be found orally. This one has to be, given intravenously, right? Then it's also used in dialysis patients and those undergoing cancer chemotherapy. This purely for prophylaxis to prevent infection. Then for penicillin-resistant pneumococcal infections, and also for surgical prophylaxis. So we found for surgical prophylaxis, if you don't have vancomycin, we talked about clindamycin. If you don't have clindamycin, which other drug that you've already learned about that is used for surgical prophylaxis?
Cephalosporins, like
Is it, do you use cephalosporins for surgical prophylaxis? Any drug that we use for surgical prophylaxis? The ladies are not speaking today. Where is I've seen Joy. I feel like I'm in a boys' school. Where's Joy? I think she's typing, means she can't talk. Well, see, peace. Do you have peace, Kingole?
Yes.
Yes. Any drug that we can use for surgical prophylaxis?
Yes. I think cephalosporins are used too.
Mm-hmm.
An example, fazolin.
Cefazolin for surgical prophylaxis. Yeah, you can use, but why do you think you should be reluctant to use cephalosporins? All right. I know we'll go look that up. Then we have for glycopeptides. We have teicoplanin. Now, this one is not one drug, and it means when analyzing, you expect it to have a mixture of 6 similar compounds that you cannot separate, right? And they're active against gram-positive bacteria only. The mechanism of action, everything else is similar to that of vancomycin. But it's more active against enterococci relative to vancomycin, but against MRSA, it's equipotent to vancomycin. Now, you expect rashes and fever, granulocytopenia, occasional hearing loss. You expect that with vancomycin as well. Then the reason for that is not that much, 1 in 2,500 people. So the uses are not any different from what you've seen in vancomycin. The uses are purely almost similar. Then we have oxazolidine-diones. An example is linezolid. Now, I've seen nowadays this drug is really being aggressively marketed, and the worst people are actually consultants because they'll be given small tips, and the very thing they think about is to prescribe linezolid for simple infections. It's actually quite risky. And wherever you'll go as a pharmacist, I think within that facility, you'll be in charge of antimicrobial stewardship. And some of the house rules you have to put is that linezolid is a fourth line, at least a third line, but mostly a fourth line drug, right? So generally very useful in management of resistant gram-positive cocci. And I have to say that this is one of the very effective last line drugs that we have currently. So effective for both aerobic and anaerobic bacillary infections. Active against MRSA, VRSA, VRE. However, not active against gram-negative bacteria. So it's bacteriostatic, but it then can exert cytoaction against some streptococci, pneumococci, and Macrolides fragilis. Now, the mode of action is that it inhibits protein synthesis by acting on early step and a site different from that of other antimicrobial agents. It binds to 23S fraction of the 50S ribosome and interferes with formation of N-formal methionine tRNA. Okay, so the insertion complex is compromised. I know you learned about the process of protein synthesis, that after the RNA gets to the ribosome and tRNA is bringing the amino acids, there's an insertion complex, right? So that one is the early step where linezolid binds. So there is a difference between where it binds and where other compounds bind, like the macrolides and chloramphenicol, right? And aminoglycosides. So that binding of linezolid distorts tRNA binding site. Remember, this is the one that is bringing the amino acids so that the chain can grow. So overlapping both the 50S, 30S ribosomal subunits and stops protein synthesis before it starts. So as such, there's no cross resistance with any other known antibiotic currently. So its mutation, its resistance is due to specific mutation targeting the 23S because it's a very unique antibiotic, right? So enterococci, among the very first group of microbes that have developed resistance against linezolid. So it's given orally, usually available as tablets. The side effects are quite too many. Okay, so no one should actually give you linezolid unless it's very, very necessary. So it's usually metabolized non-enzymatically, so you don't expect drug-drug interaction with COP substrates, and it's excreted in urine. Plasma half-life is 5 hours, like the one we saw in vancomycin. So linezolid is given, can also be given IV. Okay, so what do you expect? When you give somebody this drug, what do you expect? Usually it has very many side effects. Abdominal pain is very common. Most patients will complain about abdominal pain, nausea, taste disturbance. I know if I ask you about side effects of this drug, most of you will start with nausea and vomiting. So I'll modify my question that you give me the side effects except nausea and vomiting, right? Then we have occasional rash, pruritus, headache, vaginal candidiasis, because when you kill normal flora, you expect the fungal growth. Then neutropenia, anemia, and thrombocytopenia are frequent. But when you use it for a prolonged period, you expect in some people that such symptoms will show up. Then optical neuropathy, if given for more than 2 weeks. Drug interactions, it inhibits monoamine oxidase, and so then it means there will be interaction with serotonergic, adrenergic drugs such as SSRIs and excess dietary tyramine. And where do you get tyramine from? Which foods do we eat that you think contain tyramine?
Milk products and cheese.
Yeah, they contain tyramine, okay? So other than SSRIs, which other drugs are usually metabolized by monoamine oxidase? Like which other drugs other than SSRIs that you expect will interact with linezolid? Or which drugs are substrates of monoamine oxidases? Maybe hatujafika hapo, right? Now, lastly, we look at polypeptide antibiotics. So polypeptide, low molecular weight polypeptide compounds that have strong antibacterial activity. But we don't use them systemically. You'll find them usually as powders, usually formulated as powders or creams or ointments for topical use. For example, polymyxin B, colistin, bacitracin, and mupirocin. I'll just address their general mechanism of action. They have a detergent-like action. We use detergents to kill bacteria on the skin, but they don't have a specific mode of action. They just have a blanket effect on the cell wall, which lyses the cells and kills it. So you expect these polypeptide antibiotics usually to have non-specific mode of action, but they have an effect on the cell such that the cell wall is compromised and any microbe on the surface will have to die. So because of that, you don't expect many, you don't expect resistance, because if the action is non-specific, then the bacteria doesn't know how to start or how to stop the action of these drugs. So they're not absorbed systemically. However, you expect minimum absorption in case the skin has abrasions. They're safe. Occasionally a rash may develop. If given orally, side effects are limited to the GIT because you don't expect them to be absorbed. So the side effect will be like, they'll kill normal flora and then you expect diarrhea or patient may develop nausea. Okay, so if injected, which doesn't happen, they'll be flushing, and because you expect it to release also histamine. Then because they're of their nature, because of their nature, the bigger the drug, the more easier it is to clog the kidney nephrons. So you expect these drugs to cause serious kidney damage if injected systemically. So where do you use polypeptide antibiotics? Usually they use topically in combination with others. So you'll find them in a lot of powders used in management of some fungal infections and mixed fungal bacterial infections, and as ointments and creams for use in skin infections, right? Then bacitracin, same, used orally and to manage certain skin conditions, and you don't expect side effects owing to their ability not to be absorbed into the body. So these drugs will be found as mostly powders and creams and ointments for use generally on the skin. I want to end our lecture here, but I don't think I should end the lecture before we interact for 10 minutes in the form of questions. And in case I forgot something, some additions from you so that we can close, we can call it a day. So any questions?
Yeah, I need to get some info more from your side. We have said that, or I've seen clindamycin be prescribed mostly in skin infections and bone infections. Now, other than better tissue penetration as compared to either penicillin, cephalosporin, do clindamycin have any other advantage over these other classes in respect to bone infections and skin infections?
No, yeah, that's a good one. The option we have for drugs that have very good bone penetration is a generation cephalosporin, right? Ceftazidime. Okay, we can use ceftazidime for that. And another option is moxifloxacin, third generation fluoroquinolone, and then clindamycin. So when you look at all those options, you realize that for ceftazidime, it's the cost. It's not a very cheap molecule, right?
Yes,
yes. It's expensive. For moxifloxacin, generally we shall talk about them if we haven't, and we know that fluoroquinolones have, other than causing demineralization in the bone, their array of side effects is quite large. And that's why we say use fluoroquinolones if the benefits outweigh the risks, right? So you realize
Yes.
then that leaves clindamycin as the only choice, right?
Okay.
And that's why now even in management of Helicobacter, you realize clindamycin options are usually used as first line, then no and line, right?
Okay, thank you.
Any other question? Yes, Faith. Do you have faith? Anything you want to add? All right, restricting this to ladies. Any other question? Okay, then if I'm touched by the Holy Spirit, I may share the notes. I may consider sending the notes. I want to wish you a good day and see you next